Did your doctor tell you that you needed an office hysteroscopy with an endometrial biopsy and you just wasn't sure what that was or what it entails? Well, today I'm going to talk about the office hysteroscopy procedure with endometrial biopsy. That sounds good to you? Continue watching. Well, welcome back to my channel. I'm Dr. DuPont. I'm a board certified gynecological oncologist, and I'm passionate about educating women to live healthy and productive lives, and I believe that begins with great health. So today we're going to talk about the office hysteroscopy with endometrial biopsy. It's a very common procedure done often by a gynecologist or gynecological oncologist to evaluate some of the causes of abnormal bleeding. A lot of times, if you're having postmenopausal bleeding or irregular bleeding where the timing is off, or you're having heavy bleeding, or you're passing clots, we often want to make sure there's not something that's cancer or precancer lesion causing that bleeding. And we also want to make sure there's not something that can be easily treated, like removal of a fibroid or a polyp. And so a lot of times we'll do an office hysteroscopy because that allows us to see the uterine cavity. Now, for most of what I do when I'm looking for endometrial cancers, I'm just doing office endometrial biopsies because I don't always need to see the whole cavity. But if I have someone whose office biopsy was negative, but they're still having symptoms, then a lot of times I will add a hysteroscopy so I can see, is there something else that maybe I'm missing or that's not getting picked up on the ultrasound. So hysteroscopy, all it is a flexible camera that allows us to see inside the cavity. And typically we'll use the distending medium to distend the uterus. So the uterus is a potential space. So I tell patients when they're looking at this model of the uterus, it's not open normally. The walls of the uterus are flush. And so we'll put either fluid or CO2 gas to distend the cavity. And that allows us to kind of see inside to see, is there anything abnormal inside that's causing the abnormal bleeding? So that's why we do a hysteroscope. And then the endometrial biopsy will give us kind of a tissue diagnosis. So we'll get something to send to our pathologist. So once your doctor kind of has decided that you do need this procedure, they'll give you some additional instructions, as to what to do before the morning of the procedure and the night before. So typically what I'll do is I'll tell my patients, I want you to take a nonsteroidal medicine at bedtime the night before the procedure and the morning of. So I will use oftentimes, non-narcotic, because a lot of women do tolerate these procedures quite well. I like to use, my favorite kind of right now is Advil 2. So it'll have Tylenol and Motrin. Motrin actually has its own brand called kind of dual action Motrin. So I like these because they have both of the medicines inside. I'll have my patients take it the night before and the morning of, and then I'll also give them what's called a paracervical block. So I'll numb the area around the cervix to help with pain. I can also give them, narcotic if I think they're going to need just something stronger. So just keep in mind, there's many ways we control pain, but a lot of times these work very well and they don't have narcotics in them. So for patients that maybe can't take Motrin, let's say they had a weight loss surgery or gastric bypass and they can't take it, or they had ulcers, then I'll have them take Tylenol. Usually I'll have them take 2 extra strength the night before and then an hour before the procedure. Or I have some patients that say, Tylenol never helps me. I take it, it doesn't help. So I like to take Motrin. So they take Motrin or Aleve or any of the ibuprofen type of products. I'll have them take that the night before and the morning of. I tell them, at least with the ibuprofen, the doctor dose is like 600 to 800. So I'll have them doesn't upset their stomach. But typically, once we have reminded them to take, the pain medicine night before and the morning of to reduce the pain and reduce the cramping, then I'll have them come to the office. And we can also give them, injectable pain medicine if they forgot or for some reason didn't take their medicine. And so there's things like Toradol we can give in the office that does help with pain that's also non-narcotic. So once they come in the office, we'll go over the procedure again. I'll describe to them, why we're doing this, and they'll sign a consent form, answer any questions they may have. And then typically I will do first, I'll do exam to evaluate the position of the uterus. And then also I will paracervical block where I'm giving them some local anesthetic to the cervix. And that does help with pain. I'll let that sit for 15, 20 minutes, and then I'll come and do the procedure. So with the office hysteroscopy, very similar to the office endometrial biopsy, but with the hysteroscopy, we're going to do that part first. So we'll get a speculum, insert that into the vagina to help us see the cervix, and then we'll do that. We'll use that tenaculum which is a instrument that allows us to grasp the cervix so that we can straighten out the canal. And then we'll insert that flexible hysteroscope. And it's commonly done in the office, can be done with office anesthesia or without. And we'll use a distending medium. I normally use saline. I've used, CO2 in the past, but there's many different types of fluids that we use to distend the uterus. And typically, once the uterus is distended, we can actually see the cavity, see if there's any polyps or masses. A lot of times, with endometrial cancer, it could be contained just in a polyp. So I could do just a blind biopsy and miss that polyp because I didn't know it was there. So a lot of our new office hysteroscopes will have instruments where we can kind of grab that polyp and remove it and send it to pathology. So we're doing more of a directed biopsy than just kind of a blind biopsy that we've done in the past. So once the hysteroscopy is done, and then we'll do the endometrial biopsy. So we already had the tenaculum, then we'll just use a pipelle or kind of a little straw-like instrument to grab some tissue if there wasn't like a polyp or something else we were able to remove. We send that off to the pathologist. We'll put it in a fixative. Usually we'll use formalin, and that will preserve it. And then we send it to the pathologist and then look at it under the microscope and tell us, are there any precancer changes? Is pathology benign? Is it cancer? And that's what we're looking for in terms of, why are you having the abnormal bleeding? I do have a lot of videos on abnormal bleeding. I did a series last year on the Palm-Cohen system, which is our classification system, and how we kind of describe abnormal bleeding, and also goes over some of the causes. So if you're someone that has abnormal bleeding, please check those videos out. You'll find them very helpful. And after we have gotten the pathology report back, we'll have the patient come back to the office, and I typically will go over the results with them. I'll ask them, how they did with the procedure and, make sure that they're recovering quite well. But then we'll go over kind of our next steps and make a plan as to how we can treat or prevent the bleeding from coming back. But typically, the office hysteroscopy with endometrial biopsy is a very easy procedure. It's commonly done by gynecologists and gynecological oncologists, and it's safely done in the office with or without, anesthesia in the office. Most patients do tolerate it well. We do have to manage the pain because it does cause more pain than just the traditional endometrial biopsy. But most patients tolerate it well. There will be some patients that I know that their pain tolerance is just too low and they're not going to be able to tolerate it. And for those patients, I'll do it in the operating room under anesthesia, and I'll tell them, we're just going to do a hysteroscopy with DNC. Or if I've already done a hysteroscopy in the office and I just didn't get any pathology, or they're still having their symptoms, and I may have to do kind of a DNC in the operating room to be able to get kind of a bigger biopsy, is what I tell patients, just to get more tissue, because the endometrial biopsy, that the tube is very small, so we don't really get a lot of tissue. We just get kind of a representative sample. So even if you have a biopsy that's normal, we're not scraping the entire lining. We're just getting a representative sample. So you can have some area that was missed or wasn't evaluated just because we're just getting a portion. We're not getting all of it. And then I do have some patients that continue to bleed and their symptoms just won't go away, where I have to offer them a hysterectomy, because again, only with a hysterectomy can I remove the entire uterus and give that to the pathologist to make sure there's no hidden cancer or something that I'm concerned about, especially as a cancer specialist. But that's the reason why we do hysteroscopies. Typically, we do in the office. It's very common. Some of the instructions you'll be given is to have pelvic rest, so nothing in the vagina to prevent infections, no swimming, hot tubs, intercourse, tampons, things like that for several weeks to reduce the risk of infection. And then also I'll tell patients, some of the complications of it are you may have some pain, you may have bleeding. It's very easily treated. And typically with patients, I will tell them they'll have spotting for, up to a week or two after the procedure. If it's longer than that, they should definitely let me know, or you should let your healthcare provider know. But the procedure is safe. One of the very rare complications would be uterine perforation. I don't typically see that with the office procedures because our instruments are kind of flimsy, but it does happen more commonly in the OR when we do a DNC because those instruments are rigid and a lot of times they're metal and they can poke a hole in the uterus. The good thing about the uterus is that it's a muscle, so if it injured in any way, a lot of times it heals. What we worry about mainly with the DNC and not so much with this procedure is that our blood supply is lateral. So if our instruments go through the side, then we have to make sure there's no internal bleeding. But for most women in the office, it's a safe procedure. A lot of times the risks are, less than 1% for most women. The main thing patients have to be aware of is that it can cause pain and cramping. So, just know you may not want to go to work that next day. You may want to have the rest of the afternoon off. And then sometimes I'll tell patients, don't wear white pants. You will have some bleeding. I'll have some patients wear these nice, tan or white pants. If you have some bleeding, maybe wear a darker color just so that you don't get anything on your clothes. But it's a very commonly done procedure. And I hope that was helpful for you. I do have, again, lots of videos on this procedure and lots of videos on abnormal bleeding and some of the causes of abnormal bleeding. So if that sounds good to you, please check those out. Thank you, thank you, thank you for watching to the very end. And I'll see you next time. And until then, bye-bye.